How's it going, guys? So this is actually a very challenging question for me to discuss because we could talk about these drugs for 45 minutes, a lot of the details here. So what I'm going to do is make a shorter version of this question and a longer version where I'll just tell you straight up the correct answer first for those of you who want it. And then for those of you who want more farm, I will extend the clip a bit. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like, really appreciate it. Find me on Instagram, Mehlman_medical, MEHL_MAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the fucking question here. 39-year-old woman, 34 weeks gestation. She has 1-day history of fever and flank pain. She's febrile at 103. She has costovertebral angle tenderness in the left. This is pathognomonic for pyelonephritis. I don't think I've ever seen a question across NBME exams where they haven't said CVA tenderness for pyelo. This is pain over the flank when you percuss. And you should know that there's increased risk for pyelo in pregnancy, especially third trimester, because progesterone decreases ureteral peristalsis, okay? And also you get uterine compression on the ureters. Tangentially, progesterone also slows biliary peristalsis, which increase risk for cholesterol stones in pregnancy. Now this slide, you say no idea what I'm looking at. This is showing us a basophilic infiltrate. You see all the basophilic appearing cells, the purple, blue appearing cells? These are neutrophils, okay? This is a non-specific slide. They can show you a very similar appearing slide for, let's say, a 68-year-old dude who has prostatitis. And I mean, it would look pretty much the same. You say, yeah, those are bluish cells with basophilic cells. Those are neutrophils, okay? High yield image here. Now, I said I'd make this a shorter version. I'll hop out the answer first, which is ceftriaxone. That's how we treat pyelonephritis in pregnancy. Now, for those of you who don't want extended farm, if you're going to be an asshole and leave my clip here, fuck up the algorithm, that's okay. But at least subscribe my channel. I really appreciate it. And give the video a like. Really appreciate it. Now you can fucking leave if you don't want extended farm. Now look, whether the patient is pregnant or not, ceftriaxone is a high-yield way to treat pyelonephritis. Also, ciprofloxacin is high yield to treat pyelo and prostatitis. Okay, you wouldn't give Cipro in pregnancy, but fluoroquinol and ciprofloxacin for pyelonephritis and prostatitis. Okay, as well as ceftriaxone for either of those. So high yield drugs. If you say, well, when would I use ciprofloxacin? When would I use ceftriaxone? You could say, oh yeah, those are for pyelonephritis or prostatitis. Two solid uses right there. Ceftriaxone is also very high yield across 2CK as a general agent to use in sepsis. So you might get a patient who's got low blood pressure, high leukocytes, just some random septic shock going on, and you're like, I don't even know what the cause is. And they'll ask for the treatment. It's just ceftriaxone, okay? It's just a general agent that's used for sepsis, to my observation, across NBME material. Ceftriaxone can be combined with vancomycin for empiric treatment for bacterial meningitis. Ceftriaxone's added to regimens for sickle cell patients to cover salmonella, okay? And also ceftriaxone used for Lyme disease in pregnancy, and also just severe / tertiary Lyme disease that affects the CNS. Let's just move forward here. So clindamycin, everything's going to be the wrong fucking answer from here on out, but I told you extended farm. So clindamycin, this is 50S ribosomal subunit inhibitor. Highest yield highest yield use is pulmonary embolism. The fuck am I saying right now? Pulmonary abscess on USMLE, okay? You're going to give clindamycin, okay? That is the use across NBME exams. Pulmonary abscess, okay? It can be used in theory topically for gynecologic stuff, like we use topical metronidazole for bacterial vaginosis, which is Gardnerella vaginalis. Metronidazole can also be used topically for trichomoniasis, okay? But topical clindamycin for anaerobes, okay? Anaerobes above the diaphragm, classically pulmonary abscess. Doxycycline, wrong answer. This is a long discussion in and of itself, okay? But never give doxy during pregnancy. Never give to children 8 or younger, okay, when we talk about Lyme disease. Now, doxycycline inhibits 30S ribosomal subunit. It's one of the tetracyclines. Causes photosensitivity, all right, and teeth discoloration in children. And a long mnemonic, vacuum the bedroom, is what tetracyclines can be used to treat. So Vibrio species, in theory, acne orally, chlamydia, ureaplasma ureolyticum, mycoplasma, tularemia, H. pylori, second line, Ehrlichia chiefensis, Borrelia burgdorferi, Lyme disease, rickettsia. Long fucking discussion, right? I mean, what are we going to do? Talk about this for 45 minutes? But your high yield points for doxy is just don't fucking give in pregnancy. Don't give to children 8 or younger. Causes photosensitivity, teeth discoloration in children. Demeclocycline, it can cause nephrogenic diabetes insipidus. Doxycycline can be used in combination with ceftriaxone to treat pelvic inflammatory disease. We co-treat because ceftriaxone will treat gonorrhea. Doxycycline can treat chlamydia. Azithromycin is actually preferred to doxy for chlamydia in most cases because azithromycin is a one-off oral stat pill, whereas doxycycline's BD twice a day for a week. Let's just move forward here. So erythromycin inhibits 50S ribosomal subunits of macrolide. Not a common answer on USMLE for anything. I don't think I've ever seen this. Erythromycin, it can be used to treat chlamydia in pregnancy. Azithromycin's high yield. Azithromycin is community-acquired pneumonia empiric treatment. Okay, that shows up on 2CK exams. But when we talk about macrolides, okay, I mean, they can cause GI disturbance, so diarrhea, and it can also prolong the QT interval, all right, cause arrhythmia, and they inhibit P450. Azithromycin does not inhibit P450. Moving forward, gentamicin. This is a 30S ribosomal subunit inhibitor. It's an aminoglycoside, and it should be synonymous in your mind for gram negatives. It can also treat Pseudomonas, and you need to know very high yield that it causes ototoxicity and nephrotoxicity. So the ototoxicity need not be hearing loss or tinnitus. It can be just vertigo. The patient, the room is spinning. For renal, it's acute tubular necrosis, okay? And gentamicin, which targets gram negatives, is combined with vancomycin, which targets gram positives, as empiric treatment for endocarditis, okay? Gentamicin plus vancomycin. Ampicillin and gentamicin, that combination is used somewhat ubiquitously across different things. You can actually use that for pyelo as well, but it's not going to be assessed that way. As I said, pyelo is ceftriaxone or ciprofloxacin. Gentamicin with so ampicillin and gentamicin, that is assessed though for neonatal sepsis, meningitis, or pneumonia caused by group B strep. Okay, that's on the OBS-GYN forms for 2CK. So moving forward, trimethoprim sulfamethoxazole, this combo is used for simple UTIs in women who are not pregnant. If a woman's pregnant, we tend to give nitrofurantoin for UTIs. Obviously, pyelo, with this question, we give ceftriaxone, but TMP-SMX, this can also, the highest yield for USMLE is going to be prophylaxis and treatment for pneumocystis jirovecii pneumonia, and it's also prophylaxis for toxoplasmosis in AIDS patients. Sulfa drugs, when we talk sulfamethoxazole here, when we talk about giving any sulfa combination that can produce Stevens-Johnson syndrome or toxic epidermal necrolysis, of course. Trimethoprim inhibits dihydrofolate reductase. Okay, so methotrexate, trimethoprim, pyrimethamine, they inhibit dihydrofolate reductase. You don't have to worry about mechanism of action of sulfa drugs, even though it's a dihydropteroate synthetase inhibitor. USMLE won't ask you that. Vancomycin, this is gram-positive. So as I said, vancomycin can be combined with ceftriaxone as empiric treatment for suspected bacterial meningitis. It can also be combined with gentamicin for empiric treatment for endocarditis. Okay, so vancomycin's gram-positives. It's used to treat MRSA, methicillin-resistant Staph aureus. It can be used to treat ampicillin-resistant enterococcus. Okay, that's why VRE, vancomycin-resistant enterococcus, is a big deal in hospitals. We normally can treat ampicillin-resistant enterococci with vancomycin. And vancomycin orally, high yield for C. difficile, pseudomembranous colitis. Okay, it's not metronidazole as of February 2018. Vancomycin resistance, Diala goes to Diala-Dlac. Vancomycin can cause quote-unquote red man syndrome, which is histamine release. Lengthy clip here, right? I mean, I could go into lengthy discussion about all this stuff, but I mean, you know the deal. I'm going to continue making more content. So if you like my stuff, subscribe to my channel. Appreciate your time. That's it.